Hello and welcome everyone. In this video we are going to discuss about rheumatoid arthritis. The topics covered under this video are pathophysiology of rheumatoid arthritis, systemic effects, diagnosis, histopathology and management of rheumatoid arthritis. Let's see. Rheumatoid arthritis is a chronic, symmetrical, inflammatory autoimmune disease that initially affects small joints with varying severity and it progresses to larger joints and eventually the skin, eyes, heart, kidney and lungs are involved. The risk factors of rheumatoid arthritis include age, gender, genetics, and environmental exposures like cigarette smoking, air pollutants, silica, and occupational exposures. Onset of this disease is usually from age 35 to 60 years. Common symptoms of rheumatoid arthritis include morning stiffness of affected joints for more than 30 minutes, fatigue, fever, weight loss, tender, swollen, and warm joints, and rheumatoid nodules under the skin. Joint inflammation over time leads to destruction of joint with loss of cartilage and bone erosions. In rheumatoid arthritis, proximal interphalangeal joint and metacarpophalangeal joints are involved most commonly. And most important differential diagnosis of rheumatoid arthritis is osteoarthritis, which typically affects distal interphalangeal joint. Main pathophysiology of rheumatoid arthritis involves synovial membrane inflammation. Second is hyperplastic synovium. Third is cartilage destruction and fourth is bone erosion. Now let's learn about systemic effects. Rheumatoid arthritis involves systemic organs also. The effects are: first is elevated risk of cardiovascular events. Second is it influences the brain by causing fatigue and reduces the cognitive function. The third is it affects the lung by causing inflammatory and fibrotic disease. It affects exocrine glands by causing secondary Sjogren syndrome. And fifth, it affects the skeletal muscle by causing sarcopenia and bones by causing osteoporosis. Now let's learn in detail about diagnosis of rheumatoid arthritis. In RA, anemia of chronic disease and thrombocytosis can be seen on peripheral blood. The biomarker for RA are rheumatoid factor, ACPA or anti-CCP, ESR and CRP. Rheumatoid factor is present in 80 to 90% of patients with RA. Anti-CCP or ACPA is present in 70 to 80% of patients. The 10% of rheumatoid arthritis patients are seronegative. The presence of rheumatoid factor is not diagnostic of RA. It may be present in other connective tissue diseases such as systemic lupus erythematosus, Sjogren syndrome, scleroderma, and granulomatosis with polyangiitis. RF may also be found in patients with chronic infection and healthy individuals. RF and ACPA are present for months to years before the onset of clinical arthritis. Acute phase reactants such as erythrocyte sedimentation rate ESR and levels of C-reactive protein CRP are usually elevated in patients with active disease. Depending upon the ACPAs, there are two major subtypes of RA. First is RA with positive ACPA and RA with negative ACPA. Overall, ANA positivity, that is anti-nuclear antibody positivity, is observed in 25 to 70% of cases, as it is an autoimmune disorder. The most common patterns found on indirect immunofluorescence assay are speckled pattern and nucleolar pattern. If we examine synovial joint fluid in rheumatoid arthritis, then it reveals leukocyte count between 1500 to 25,000 per cubic mm, and it is predominantly polymorphonuclear cells. The synovial fluid in RA will also reveal low C3 and low C4 level despite elevated serum levels. Now let's learn about clinical scoring system for RA. There are 10 criteria. After performing a total of each criteria, and if the score is more than 6, then we can say that the patient is suffering from rheumatoid arthritis. Let's learn the stages of RA, which is defined by American College of Rheumatology. Stage 1, no destructive changes on X-ray. Stage 2, presence of X-ray evidence of periarticular osteoporosis, subchondral bone destruction, but no joint deformity. Stage 3, X-ray evidence of cartilage and bone destruction in addition to joint deformity and periarticular osteoporosis. Stage 4, presence of bony or fibrous ankylosis along with stage 3 features. Let's see histopathology in rheumatoid arthritis. The histopathology of rheumatoid synovium reviews intense fibroblast-like synovial cells activation, proliferation, and subsynovial accumulation of T cells. The appearance of synovial tissue can appear similar to secondary lymphoid tissue such as lymph node. Rheumatoid synovial tissue become invasive, eroding into bone and causing marginal erosions. New synovial blood vessel growth can be seen, and this leads to transmigration of lymphocytes and polymorphonuclear leukocytes into synovial fluids. The rheumatoid nodules initially have a small vessel vasculitis phenomena followed by chronic inflammatory granulomatous phase. The development of rheumatoid nodule is frequent in rheumatoid arthritis involving dermis or subcutis in periarticular areas. Now let's see the management. Management are of two types. First is non-pharmacological interventions and second is pharmacological interventions. The goal of non-pharmacological interventions for RA is to decrease anxiety and depression, to reduce pain and to increase mobility. The polyunsaturated fatty acids like docosahexaenoic hexanoic acid DHA and eicosapentaenoic pentanoic acid EPA are useful and which improves depression significantly. Rest, occupational therapy, physical exercise and surgery is indicated under the non-pharmacological intervention. The joint surgery is used only in severe stages of RA, and they are TENS, synovectomy, radiosynovectomy, arthroscopy, osteotomy, joint fusion, metatarsal head excision, arthroplasties, or total joint replacement. The goal for medical management of rheumatoid arthritis are to reduce joint inflammation and pain, maximize joint function, and prevent joint destruction and deformity. Main three types of DMARDs are available. DMARDs are disease modifying anti-rheumatic drugs. The first is conventional synthetic DMARDs, second is biological DMARDs, and third is small molecule DMARDs. The conventional synthetic DMARDs are methotrexate, leflunomide, sulfasalazine, hydroxychloroquine. The biological DMARDs are TNF alpha inhibitors. Examples are infliximab, adalimumab, etanercept, golimumab, certolizumab. B cell depletion and inhibition antibodies. Examples are rituximab, belimumab. T cell targeted therapies like abatacept, IL-6 inhibitor, tocilizumab, IL-1 inhibitor, anakinra, osteoclast differentiation factors like denosumab. And third is small molecule DMARDs, and they are tofacitinib and baricitinib. So these are the references for this video. Hope you like it. Thank you. See you in the next video. Bye.